Okay, it is 12:01 p.m. on the East Coast. Hello and good afternoon, everyone, or good morning, depending on where you are. Welcome and thank you for joining us today for another webinar from the GIN North America community. I am Dina Baptiste, a member of the GIN North America Steering Committee. And thank you for taking the time out of your busy schedules to join us today. Now, if this is your first time on one of our webinars, I will take a few minutes just to introduce you to who we are. We are a regional community that's a part of the larger GIN Guidelines International Network, also known as GIN. Our GIN North America community includes members from Canada, Mexico, and of course the United States. These webinars are one of the many ways we facilitate sharing and collaboration in our regional community. This year we have started some chats, coffee talk chats. You may see those advertised, and we encourage you to participate in those in addition to our webinars. Just a reminder that this webinar is being recorded, and the recordings along with the past webinars from the GIN North America community can be accessed on the GIN YouTube channel. The recording of today's session will be made available within about a week or so, so please share with others who missed today's live session. We encourage you to visit the GIN website for more information, or contact us to get more information about GIN. The GIN website is a great platform for the latest news in the guidelines community and resources for members, or if you would like more, if you're not yet a member and you would like more information and how to join. Also, if you're a member and you're not yet connected on GIN Connect, please sign up, as this is the primary platform or mode of communication for connection to resources and events such as this webinar for our members. A quick reminder, an important one for everyone. This year, the Guidelines International Network Conference will be hybrid. So for those of us who may have challenges with getting approval for travel, that is great. It is scheduled for September 19th through the 22nd in Glasgow. Abstract submission and registrations are currently open. And just a note that abstract submission closes on April 13th. So there's still a bit of time to submit if you have an interest in that. I believe the deadline was extended to the 13th. You may visit the conference webpage for registration and additional meeting information. And just note that early bird registration closes on July 6th. Now, to get right into our talk today, just a few housekeeping items before I introduce our speakers. The session is being recorded. All participants were muted to facilitate a smooth recording, but just in case, please check that your audio is on mute. We have allotted time for questions at the end of the presentations, so we ask that you submit your questions using the Q&A feature on your Teams app, or if you're on your laptop, or you may post them in the chat. And the speakers will respond to as many as possible after all the presentations are completed. So today we have 3 speakers joining us to discuss their research and work on improving stakeholder involvement in guidelines development and implementation. First, we will hear from Dr. Jennifer Petkovich, who is an affiliate investigator at the Briere Research Institute and a research associate at the Ottawa Center for Health Equity. She is also the coordinator for the Multi-Stakeholder Engagement Consortium and the Muse Guideline and Muse Evidence Synthesis Project. Then we will hear from Dr. Marisha Palm, who is an assistant professor working at Tufts Institute for Clinical Research and Health Policy Studies and Tufts Clinical and Translation Science Institute. Dr. Palm has over 15 years of experience bringing diverse groups of stakeholders together to make healthcare research more relevant and impactful. And her prior work in the UK involved working in health services and as a public engagement expert at regional and then at national level. And Dr. Palm has led teams first at Dartmouth Institute and now at Tufts. And her work focuses on growing multi-stakeholder, cross-disciplinary, and trans-organizational partnership with emphasis on communication and collaborative work. And then Dr. Maya Gernstein from the Center for Evidence and Practice Improvement at the Agency for Healthcare Research and Quality, AHRQ, will be presenting some of her work on shared decision-making and implementation of guidelines. Her work focuses on promoting advances in shared decision-making through research and implementation. Prior to joining AHRQ, she was a health services researcher at the George Washington University and an associate director for patient-centered outcomes at a health economics and outcome research firm. Her previous work also included research that focused on capturing the expressed need and priorities of patients, medical decision making, and the patient and clinician perspective in addressing health inequities in care. So with that, we will begin our presentations. These are the disclosures from our speakers today and myself. Okay.
Okay. Thank you, Dina. Thank you for inviting us to talk about our project. And my name is Jennifer Petkovich. As Dina said, I'm the coordinator of our multi-stakeholder engagement consortium and this guidelines project. So our work to develop guidance around multi-stakeholder engagement and guideline development. So before I tell you about the project, I'll just give you a bit of background to the Muse Consortium. So in 2015, some researchers with common interests in stakeholder engagement in research and evidence synthesis and guidelines worked together to establish the Muse Consortium. The group has now grown to have over 160 members from over 20 countries, all with different backgrounds and representing different stakeholder groups. We currently have funding from the Canadian Institutes of Health Research for 2 projects. The first one is to develop some guidance around stakeholder engagement in guideline development, and that's the project that I'll speak to you about this afternoon. And then the second project is about stakeholder engagement and evidence synthesis. So it's related, but the goal would be to develop guidance around evidence synthesis there. And as I mentioned, we have many members of the Muse Consortium. These are just a few of the organizations that have been involved with us since the beginning. And this map shows where our members are located. So we do strive to be a global organization. We have a lot of members who are based in Canada or the US, Australia, or the UK, but we are always recruiting new people to join the Muse Consortium or to participate in our projects. And so I'll leave some information for anybody who might want to be involved at the end. Okay, so the Muse Guidelines project. The goal is to develop a stakeholder engagement extension of the Gin McMaster Guideline Development Checklist. So the idea would be that we would provide guidance for guideline developers about how to engage with different stakeholder groups throughout all stages of the guideline development process. So who to engage with and how, and then also how we might be able to facilitate equitable engagement or manage conflicts of interest with multiple stakeholders, and then evaluating the impact of engagement. So I'm sure most people have seen this, but just in case, the Gin McMaster Guideline Development Checklist was originally published in 2014. It was led by Holger Schoenemann and published in CMAJ. And so we are working with the 18 topics of the Gin McMaster Guideline Development Checklist. So within these 18 topics, there are 146 steps of the process that have been organized into these topic areas. And so we would like to provide guidance at each of these 18 topics. And so I'll provide you with some definitions that might help to understand what we're doing. So who are stakeholders? In our work, we define stakeholders as an individual or group who's responsible for or affected by health and healthcare decisions. And we've identified 10 groups or categories of stakeholders. We call these the 10 Ps. So we are referring to our 10 Ps framework. So we've got patients, caregivers, patient organizations, members of the public, providers of healthcare, policymakers, program managers, who are those who manage health programs but aren't necessarily delivering the health care, principal investigators and all the members of a research team, those involved in peer review or peer review editors, payers or purchasers of health services, payers or funders of health research, and product makers. And I do just want to acknowledge that we've had a lot of discussions within our group about issues with the term stakeholder. So especially within the Canadian context, the term stakeholder and continued use of it is disrespectful to Indigenous populations. So we are actively searching for an alternative term that we could use. We've come up with a few possibilities. These are included on the slide here, like partners and knowledge users or constituents. But we haven't found a clear answer in the literature or from our group of what would be the best term to use. So we are currently asking for help on what term we should use to replace stakeholder. So we have a small survey. It just is a list of terms. You can choose those that you think are best. You could suggest a new term that we maybe haven't considered. You could, if you're interested, scan this QR code and then just give us your opinion on what might be a good way to replace that word. And I can drop the link in the chat later. Okay, so the next definition is engagement, and what do we mean by engagement? For our work with guidelines and with the Muse Consortium, we've defined engagement as an active partnership between stakeholders and researchers in the production of healthcare knowledge or evidence, that it results in informed decision-making about the selection, the conduct, and the use of the research. And we use the term engagement, but we do acknowledge that in different places, other terms might be used, but mean the same concept. So collaboration or partnership, a lot of our UK colleagues use the term involvement, but we all are talking about the same concept of this active partnership. And then we also needed to define some levels of engagement so that we could give guidance about how you can engage with different groups within the guideline development process. So we started with the Arnstein ladder, which you can see here on the slide. But in our work, we focus on the top 5 levels. The bottom 2 levels are more of a pushing of information towards the stakeholders without receiving information from them. So we focus on the top 5 and have simplified these to 2 levels of engagement. So we're talking about whether our stakeholders are involved to provide advice or feedback, or if they're participating in decision-making. And so if they're participating in decision-making, they have an equal role in the guideline process. So they have equal voting and their opinions are equally weighted in discussions around all aspects of guideline development. And I should just say also that we aren't saying that one group would have a specific role throughout the whole guideline development process. And what we're trying to do is show that for different topics of guideline development or different aspects of guideline development, you may engage with people in a different way, and you might engage with the same group differently throughout the whole process. But I think Mara will tell you a bit more about that in a few moments. Okay, so the Guidelines project, we did publish a protocol that outlines the whole project. And we do have some protocols for systematic reviews published. And I just show you those to explain how we're getting to the final guidance. So we started with looking at what already exists in the literature. So how people already said that stakeholder groups should be engaged and what that engagement should look like. What are some of the barriers and facilitators to guideline development, stakeholder engagement in guideline development? What are some of the issues around conflicts of interest? And what are some of the impacts of stakeholder engagement on the guideline development process, but also on the guideline that gets produced? And then we worked with the Muse Consortium to identify individuals who could serve as leaders for the different stakeholder groups. So of our 10 Ps, we identified 1 to 4 individuals who represent that stakeholder group and who could help us lead the development of the guidance for their stakeholder group. So we conducted an international survey last summer, and then we worked with the co-leads to develop an interview guide so that we could get some more clarification on those survey responses or some more information about how we might develop the guidance. And so where we're at now is sort of around here at stage 4, where our co-leads are helping to draft the guidance so that we can have a consensus meeting with the whole Muse guidance team and come up with some guidance papers. So this is just a summary of who's contributed so far. For this project, we have 26 co-leads, so people from our stakeholder groups. We also received almost 200 responses to the survey. And then we've just recently finished the interview process. So we conducted 42 interviews, almost all of those conducted by our PhD student, Olivia Maglid, who's probably on the line now. So a tremendous amount of work with over 200. So over 200 people have contributed to the project so far. And this map shows where those 200 people are located. It's pretty similar to the Muse Consortium map, but a little bit different because we did get survey responses or interviewees who have never been involved in the Muse Consortium before, so completely external to the project, who gave us some feedback about how we can engage with the stakeholders throughout the guideline development process. So this is our plan. The goal is that we will have the 18 topics of guideline development and our 10 Ps, and that we will be able to fill in each of these cells with some specific guidance about how each P group could be engaged for each topic. So should that group be engaged in decision making? Should they be engaged to provide advice or feedback? Or maybe the stakeholder group has decided that they don't think they need to be engaged in that group. And so we would like to be able to provide some information about each of these and some description of why that might be the decision that we've made. And Mara will talk a bit more about how we can handle making this as useful as possible, but also as feasible, because that's a lot to ask from a guideline development team. So our next steps are to work with our co-leads and get our draft guidance ready. We'd like to present it at a grade meeting. And our goal is to have the guidance completed by the end of the summer so that we can submit it in September. And as I said, we're always interested in getting people to join the Muse Consortium or specific parts of the project. So you can get in touch with me or find our website or find us on Twitter. And now I will pass it to Mara, who will tell you a bit more.
All right, thanks so much, Jennifer. I'm just waiting to see now if I've got control. See? All right, I might have control. We'll see. Thank you so much, Dina, for the introduction at the beginning. I really appreciate the invitation. My name is Mara Palm. I'll be building on the information that Jennifer has just provided about, oh, it looks like I didn't get control. My request for control was not accepted.
Oh, you
okay.
are.
I do have control. It's lied to me. Okay. All right. I'll assume I have control. So like I said, I'll be building on the information that Jennifer has just provided about the work that Muse has been doing to develop a plan for stakeholder engagement and guideline development. This presentation will really focus in on the patient and public engagement groups. Just a slight delay there. So I think Jennifer went through all of the guideline stakeholders that Muse had mapped out and discussed. My interest and my expertise is really in the area of patient and public stakeholder engagement. So in my presentation, I'll be discussing these two groups specifically. And I should say that this data is new. It hasn't yet been published. So the caveat here is really that we're still working with the data and building on it. And our conclusions and our direction are still subject to change. Right. Oh, did I go too far? Okay, there we go. As Jennifer has said, at Muse, we believe that it's important to include a diversity of perspectives when developing healthcare guidelines. And not only does this intuitively feel like the right thing to do, in fact, inclusion of diverse perspectives has also been shown to increase the knowledge and skills available to make decisions. Therefore ensuring a more sound and considered conclusion. So it's important to say that some consider patients and public to be sort of within the same grouping. And we did discuss this as a Muse consortium, and we explicitly decided to divide these groups into two separate types of stakeholder. Our rationale was really that their perspectives and the value that they would bring to the conversation would be different. So these are the definitions of patients and members of the public. And we felt like patients or people advocating for them would come with a deep knowledge of those who have experienced the condition of interest, whereas members of the public would be a little bit more removed from the condition and would bring curiosity around the evidence, recommendations, and use that could help to shape them for broader understanding and impact. Therefore, we had both patient and public members engaged at multiple levels on this project, as project co-leads, as survey respondents, and as interviewees. Right. I know you had a quick view of this earlier. So here I've actually just plucked out the patient and public survey respondent characteristics from that broader table of stakeholders that I think Jennifer shared briefly earlier. So it's important to say this survey was conducted using SurveyMonkey. Respondents were asked to read a description of each stage and indicate whether they wanted to be engaged as decision makers, as advisors, or whether they didn't think that their engagement was necessary. And they could also indicate how important engagement at each stage was to them. So whether it was mandatory, whether it was desirable, or whether it felt like it was more optional. So in terms of the methodology here, our consortium membership list was contacted, the Campbell and Cochrane Equity Methods group was contacted, and we also used social media to reach a large number of potential survey respondents. So you can see the survey respondent characteristics here. And I think the more mathematically inclined here might notice that the numbers don't tally. That's because we do have significant numbers of missing variables for these particular respondent characteristics. But you can see that it looks like we have larger numbers of women responding, so almost 3 times the number of men. We have larger numbers of folks from higher income countries than lower by nearly 10 times. And the pattern when we asked about respondents' previous experience with guideline development was a little bit different between patients and members of the public. So there were more patients who had experience, 25 versus 10 who didn't, whereas members of the public were really split in their reports of experience. So we had 9 who reported having experience and 10 without. So let's see, there we go. So this is a little bit of an overview. Jennifer mentioned the 18 stages of the GIDMIT Master Guideline development process, and there are just too many to list in detail here. So I thought I would include them as sort of flags, with one leading to the next, in order to just highlight where we're getting to consensus regarding engagement and where there is still some ongoing discussion. And just as a reminder, this list is the result of this 3 stages of work that Jennifer had mentioned. So 1, discussion amongst the diverse and international Muse group, culminating in structured feedback from that group. Then just surveys that were distributed pretty widely to elicit feedback from each group, followed by those in-depth, semi-structured interviews asking for additional detail and understanding. So after all of that careful collection of information, there are still areas of uncertainty, which sort of gives you a glimpse into the complexity of this work. So the stages where there is agreement here, which is just the majority, discussion and the data gathered indicates that patients and public should be involved at a decision-making level in steps like priority setting, identifying target audience and topic selection, question generation, considering the importance of outcomes, interventions, values, preferences, utilities, wording of recommendations, and dissemination and implementation. Okay, so to focus briefly on those stages where we don't have consensus, you can see that there are a few where the decision being made is really between advice and decision making. So there isn't a question of not having any role, but really between the two, the sort of advisory role or more of a decision making role. And you can see the organization and planning at the start of guideline development, and then in those final stages of developing recommendations, evaluation and use, and finally updating. And then in the middle, there are these systematic review steps where there's interest in engagement alongside this understanding that there are these are the specific steps for which training and additional expertise would be necessary for any kind of intensive engagement. So these are our sort of TBD stages. And I'll say a little bit more about our thinking after I talk about the interviews. So I heard the survey numbers earlier. In terms of the stakeholder interviews, we spoke to 7 patients and 5 members of the public. And the semi-structured interview guides were iteratively developed. They were developed alongside the Muse co-leads for each of those stakeholder groups. And in the interviews, we asked patients and members of the public to review the survey findings and give us their thoughts. So we wanted to understand whether they agreed with the level of engagement proposed at each stage of guideline development and why or why not. So these are the interview themes. So some interesting and helpful themes came out of these interviews. There was a really clear feeling, both from the patient group and the public group, that they wanted to be engaged from the outset of guideline development right through till the end, and sort of in an ongoing way in terms of updating. So this was really part of a desire to be involved often at that decision-making level. So to really have a seat at the table, to be positioned to impact guideline development rather than be involved in a sort of more tokenistic way. So there continue to be some areas where there is this split between engagement at a decision-making or an advisory level, and that recognition that, especially in areas where evidence is being systematically identified and their quality is being assessed, but also in general, preparation, training, support are really required for meaningful engagement. So you saw in the survey characteristics overview that patient and public respondents had varied experience with the guideline development process. And this was also true of the people that we interviewed. So there was really a strong push for decision making at some stages where this would actually be practically difficult. So one of our takeaways from these interviews was that, some interviewees may be thinking about engagement in the guideline development process in more of a sort of conceptual way rather than a practical way. So they might be enthusiastic about the opportunity for engagement at a decision-making level, but not fully appreciate some of the systems and structures that are part of each step. So some of the 18 steps of the Jim McMaster guideline development process are generally sort of set by the secretariat, the organization, the chair, the methodologist, and including other stakeholders like patients and members of the public as decision makers in these particular stages would require a significant shift in process and potentially have impact on timelines. So a wider group would really have to consider, alongside patient and public members, how important this would be, whether this would be beneficial enough to make these changes, and then how many changes would be implemented. So I mentioned before that there was this recognition that some steps require these more technical skills, may require support and training. So as one of the next steps, we're sort of thinking about, bringing stakeholder groups together to really discuss some of these more practical considerations around engagement. So to wrap up, our conclusions are that it really is so important to engage with stakeholders about their desired role in guideline development. And it's really important to do this at multiple different levels. This is something that we have taken and will continue to take very seriously. It's really clear that patients and members of the public are keen to take an active role as partners and decision makers in guideline development. So some of the Jim McMaster steps do allow for relatively easy engagement, and engagement can be dovetailed, it can be aligned nicely with current processes. In other cases, we really need to consider creatively whether and how patient and public members are engaged. Determining that they should be engaged is really only the first step. So we're sort of halfway through the first step of this. And we'll also have to really think carefully about how this is implemented, what supports and processes are developed to make this a reality. And I'll close with that. I think I'm handing over to Maya here, so I'll stop control. And I just want to say thanks so much, everyone. I look forward to hearing from you in the question and answer session.
Thanks, Mara. I am waiting to see that I have control here. All right, there we go. So hi, everyone. Thank you for the opportunity to speak to this group today. Mara and Jennifer have spent some time talking about stakeholder engagement in the development of clinical guidelines. And as an extension of this, I'm going to spend some time talking about the implementation of guidelines, and more specifically, the relevance and the importance of patient-centered communication and shared decision-making in that implementation process. So to revisit my disclosures before I get started, I work for the Agency for Healthcare Research and Quality, but the statements that I make in this presentation don't represent the official position of AHRQ or the U.S. Department of Health and Human Services. So when we think about stakeholders for the implementation of guidelines in practice, clinicians come to mind as a very obvious key group of users and implementers of clinical guidance. And while clinicians do represent a critical stakeholder in the implementation of guidelines, it's important for us to remember that patients and the public are really the ultimate end users of guideline-based care. And based on the distinction that Mara and Jennifer have made in their presentation between patients and public, I think it's more accurate here maybe to say that patients are really the ultimate end users of guideline-based care. And the ways in which guidelines are interpreted and implemented in clinical practice have profound impacts on patients and the quality of care they receive, their experience with the healthcare system, and with their clinical providers. So with this in mind, I'm going to spend some time talking about shared decision-making as an important aspect of patient-centered guideline implementation. So first, what is shared decision-making? Shared decision-making, or SDM for short, is a collaborative process where patients and clinicians work together to make healthcare decisions. So those decisions are informed by evidence, they're informed by the care team's knowledge and experience, and by the patient's values, goals, preferences, and circumstances. And I underline and bold the last part of this definition because this is really the piece that often gets lost when we implement guideline-based care and we counsel patients on the care options that are available to them. Shared decision-making can take place during a single visit or across multiple visits. It can happen with one or several clinicians or other members of care team. Family members and caregivers can also play an important role in shared decision-making, and tools and resources, some of which we'll discuss briefly later, can be used to help patients and clinicians prepare for and engage in shared decision-making. So why SDM? Why is shared decision-making such a critical component of person-centered, equitable, evidence-based care? When shared decision-making is done well, it supports the fundamental principle that patients lead decisions about their healthcare while still valuing the role that care teams play in making sure that patient decisions are informed by the best evidence. Research has shown that shared decision-making increases patient engagement in decision-making. It's been shown to improve the patient and clinician experience, as well as the healthcare experience and trust in providers among racial, gender, and sexual minorities, getting at the health equity piece. Before we dive any deeper into the role of shared decision-making in the implementation of guidelines, I want to spend just a few moments dispelling a common misconception about shared decision-making in the context of guideline-based care. Since the discussion of patient values, patient goals, their preferences, their circumstances is a critical piece of SDM, it can seem on the surface that shared decision-making and guideline-based care may at times be in tension with one another. So for example, if a patient's goals and circumstances lead them to prefer a care plan or a course of action or a treatment that differs from the guidelines recommendation, how do we engage in shared decision-making and still provide evidence in guideline-based care? So yes, SDM supports that fundamental principle. Patients lead decisions about their healthcare. But another essential element of shared decision-making is that the patient is provided with the information and the guidance they need to ensure that their choices are informed by the best evidence. The challenge, however, in doing this is that existing guidelines often do not address how to accomplish this balance, how to translate evidence from the population to the individual, how to engage patients in decisions by discussing the evidence in guideline-based care in an effective and patient-centered way, and how to, and this is where I think many struggle, reconcile patients' preferences and social norms with best evidence. So shared decision-making can actually be a bridge between guidelines and clinical practice. It provides a structure for discussing clinical practice guidelines with patients in a way that is evidence-based, but is also patient-centered and also prioritizes patients' goals and preferences. There are several published models for shared decision-making in the literature. The Agency for Healthcare Research and Quality SHARE approach streamlines one of these models, the 9 essential steps of SDM identified and published by McCool and Clayman, into 5. And these 5 elements for shared decision-making make together give patients and their clinical providers the opportunity to explore and compare the benefits, the harms, the risks of care options through a meaningful dialogue about what matters most to the patient. So the SHARE approach's 5 essential elements include seeking your patient's participation, helping your patient explore and compare treatment options. This is really where guidelines and evidence supporting them would be discussed. Assessing your patient's values and preferences, reaching a decision with your patient, and evaluating, sometimes this is over time, that decision with your patient. ARC has also developed a shared approach curriculum to support the training of healthcare professionals on how to engage patients in their healthcare decisions and integrate these essential components of SDM into practice. The curriculum includes a collection of things like reference guides, slide sets, other resources, all designed to support the implementation of SHARE. So I would encourage anyone who's interested in thinking more about integrating SDM into practice to visit this ARC website and spend some time with these resources. So when thinking about the role of SDM in the implementation of clinical guidelines, I think it's helpful to look at a couple examples where shared decision-making can be used with the implementation of clinical guidance to better meet our goals of providing high-quality, evidence-based, equitable patient-centered care. So let's first look at the USPSTF. So the U.S. Preventive Services Task Force is an independent volunteer panel of national experts in disease prevention and evidence-based medicine. The task force works to improve the health of people by making evidence-based recommendations about clinical preventive services. So the task force assigns one of 5 letter grades, A, B, C, D, E, sometimes I if there's insufficient evidence, to describe their recommendation and its strength. So they define A recommendations as having high certainty that the net benefit is substantial based on the evidence, and their B recommendations as having high certainty that the net benefit is moderate, or moderate certainty that the net benefit is moderate to substantial. In both grade A and B recommendations, the task force recommends that the service is offered or provided. And even in the early 2000s, the USPSTF was already talking and publishing about the value of engaging patients in shared decision-making when discussing and making decisions about these preventive services. In a publication from 2004, the USPSTF reasoned that shared decision-making for preventive services can be recommended on multiple grounds. From an ethical perspective, it promotes patient autonomy. It protects the integrity of the patient as an independent and rational decision maker that's capable of self-determination. From an interpersonal perspective, shared decision-making promotes trust in the patient-clinician relationship. From an educational perspective, SDM improves knowledge about preventive care options. It creates more realistic expectations about their benefits and harms, and it reduces that decisional conflict that can be associated with feeling uninformed. And then finally, from a utility perspective, the quote unquote best choice for decisions that involve trade-offs, which most decisions do have trade-offs, can only be made by incorporating the personal preferences and circumstances of the patient. So in 2022, so just this past year, the USPSTF published a piece on collaboration and shared decision-making between patients and clinicians in preventive healthcare decisions. And in that publication, they reaffirmed that having informed and involved patients is a core value and an ethical imperative in healthcare. And that while being informed and involved is that core value, shared decision-making can act as a means to that goal. So even for these A and B recommendations, in this article, the USPSTF recognized that some patients will have values and preferences, including their perception of the magnitude of their risk of a condition or the benefits they may gain, that makes certain preventive services less of a priority for them. Some patients may, for example, be simultaneously navigating multiple chronic conditions and treatments. They may be impacted by social determinants like financial hardships, challenges with living arrangements, transportation, or a whole host of other factors and feelings that contribute to their ability to support or have trouble supporting certain prevention activities. And this type of complexity can really only be captured and addressed when shared decision-making discussions are occurring with patients alongside the implementation of these guidelines. Another great example of the value of shared decision-making in the implementation of clinical guidelines can be seen in the 2021 guideline for the evaluation and diagnosis of chest pain. This was developed by the American College of Cardiology and the American Heart Association Joint Committee on Clinical Practice Guidelines. The published guidelines provide a helpful synopsis where they highlight the top 10 key take-home messages for the evaluation and diagnosis of chest pain. And there, among those 10 key recommendations at number 4, they highlight shared decision-making. The developers of this guideline recommend that clinically stable patients presenting with chest pain should be included in decision-making, that information about adverse events, radiation exposure, costs, and alternative options should be provided to the patient to facilitate discussion. The guideline recommends that SDM is appropriate for both low risk and intermediate risk patients who present with acute chest pain, and that the accurate and understandable communication of risk is part of that shared decision-making process. That process also includes a discussion of options for testing, for admission and observation, for outpatient follow-up, but all in the context of the patient's circumstances and goals and preferences. The guidelines based this recommendation on a single center randomized trial of adults presenting to the ED with chest pain, who were being considered by the treating physician for admission. And the study found that patients randomized to SDM, facilitated by a decision aid called Chest Pain Choice, which we'll talk a little bit more about decision aids in a moment, had greater knowledge, were more engaged in the decision process, and they less frequently decided to be admitted to the observation unit for stress testing. So the developers of this chest pain recommendation have really made clear that they see shared decision-making as essential to the implementation of this guideline, and they provide a pretty compelling rationale for it. So far, I've been talking about all the reasons why shared decision-making is so critical to patient-centered implementation of guidelines. But I also want to acknowledge that the work of shared decision-making is not easy. In shared decision-making, patients and clinicians have to arrive at a clear and useful understanding of the patient's situation. And then through conversation, they have to discover which of the evidence-based options make sufficient intellectual, practical, and emotional sense. This is a real challenge in the busy context of care. And for this reason, clinicians often do not engage patients in shared decision-making, or they struggle with how to do so when they're juggling competing demands. Even when organized evidence in the form of guidelines is available, clinicians might be uncertain about which decisions to prioritize for shared decision-making. They might struggle with how to communicate technical concepts in a simple way that is accurate, balanced, and understandable. This is a tall order for all scientists who struggle with this. And they may not be sure how to best elicit that kind of relevant information from patients about their lives, their goals, and their preferences. So while we won't be able to solve all these many challenges of patient-centered guideline implementation today, I can at least offer some strategies to think about that might help address some of the barriers to SDM and guideline implementation. So first, when appropriate and not in an urgent scenario, these shared decision-making discussions can be staggered across several office visits, focusing first on the issues that are mutually identified as the highest priority and then deferring other discussions to a later date, or the initial discussions in the office can represent that first step in the SDM process. Patients and families can review information at home, further consider their preferences, and then make a final decision with their provider at a future visit. Practices can also think about involving other staff in the SDM process, so taking a team approach to this. This can allow the clinician to focus their time with the patient on answering questions and really coming to that determination. Evidence summaries and easy-to-use shared decision-making tools that are developed alongside recommendations can also be a really helpful way to support the work of SDM. Few guideline developers are doing this routinely, but that can be an area of growth in the future. And then finally, healthcare professionals and practices can consider using decision aids. So what is a decision aid? So a decision aid is a tool that is designed to help people participate in decision-making about healthcare options. They provide patients information on their condition, their management options, and then they also help them clarify and communicate the personal value that they associate with different features of those options. So decision aids have been shown to promote patient participation in medical decision-making and also enhance patient knowledge about a decision. But of course, not all decision aids are built equal. Good quality decision aids offer balanced, unbiased, evidence-based information in addition to a way to clarify the patient's values. They come in multiple formats. They can be pamphlets or web-based tools or videos or decision boards or flashcards or audio-guided workbooks. But research has shown that decision aids that are detailed, that present probabilities in an understandable format, that give examples, that provide personalized guidance, these are more acceptable and useful to patients than those that do not integrate these components. I do want to point you to the Ottawa Hospital Research Institute. So it's a great resource for already available decision aids. They maintain an online inventory of decision aids across a wide variety of conditions and care options. And they also include quality ratings of these instruments based on IPDAS, which is the International Patient Decision Aid Standards. So the link to the Ottawa database is on this slide, as well as an example of how they present the quality rankings of each of these instruments based on those published standards. So there are hundreds of decision aids formatted in a wide variety of ways, but I thought it would be helpful to walk through one such decision aid. This is an online decision aid tool developed by HealthWise, which is a nonprofit organization that develops many of these tools to help people make better, more informed health decisions. The topic of this particular decision aid is low back pain and should I try an epidural steroid shot? The topic is not particularly relevant. It's just that I wanted to show you the way the instrument is structured to address 6 different areas. So if you are on a website, you'd be able to interact with the tool, scroll down each page. You could open and close various subsections. You could click across each of the numbered headers. In this first section, get the facts, the tool provides the patient information on their options and answers some frequently asked questions about the treatments that are available to them. The second section, make sure the slide moves forward, is titled Compare Options. And that helps the participant compare options in a side-by-side table, also provides some testimonials from other patients that may be helpful to navigating the choice. The third section is titled Your Feelings. It focuses on the participant's feelings about these options. It asks the patient a series of questions to help them sort through what matters to them most. At the top of the section, it actually reads, your personal feelings are just as important as the medical facts. Think about what matters most to you in this decision and show how you feel about the following statements. Just really reaffirms to the patient that their values and goals are a really integral part of the decision-making process. The fourth section, oh, I went forward one too far. Oh. Okay, there we go. The fourth section, your decision, asks the patient to indicate what option they're leaning towards, given all the information they received, the questions they've answered, and how strong they are in the feelings about that decision. The fifth section, which is quiz yourself, offers the patient a quiz that helps them gauge their understanding of the information they were provided. And this is to ensure that they're making choices that are informed by evidence that they actually understand. And then the final section, section 6, synthesizes all this information in a summary for the patient and their clinician if they're working through this together. And that summary includes the patient's decision, their confidence in that decision, their knowledge of the facts, any next steps given the choices that they've indicated they're leaning towards, and a summary of what they have indicated matters most to them. And again, this is one of many examples. It can take many forms, but I thought it was helpful to at least walk through one of these tools so that this becomes a little less abstract. I'm not sure exactly what I did now, but if I click this, okay. So since this is the Guidelines International Network, I wanted to point to the fact that the National Institute for Health and Care Excellence has actually published guidelines for shared decision-making. So these guidelines cover how to make shared decision-making part of everyday care. It includes recommendations on embedding SDM at the organizational level, on putting SDM into clinical practice, recommendations and guidance around patient decision aids, and also around communicating risks and benefits and consequences. And I included a link to the guidelines here in case anyone's interested in reading them in more detail, but I thought it was important to highlight that shared decision-making is itself a guideline-based intervention. And then finally, I've just put forward a few questions for the for JIN and its members and guideline developers in general to think further about. How have we considered shared decision making in our guideline development or recommendation writing? Would it be appropriate or helpful to offer a decision aid when we release a guideline? And do we think a decision aid will lead to the outcomes we are hoping for? And what needs to be included in a tool to ensure this? And then what additional information do guideline implementers really need to effectively put patient-centered, guideline-based care into practice? So with that, thank you all so much for your time. My contact information is on this slide, if I can get it to come up. And if anyone wants to reach out, I look forward to hearing from you and your questions. Maybe Dina, you can get the slide to move forward. There it is.
Okay, and thank you, Maya, Jennifer, and Marisha. I am going to take a look at our questions now, and there is a question here on, is there on, and this is for you, Maya. Is there any guidance to help physicians engage in shared decision making when patients convey a total and complete aversion to a particular preventive care or intervention? And vaccine is an example.
Yeah, that's a really interesting question, and one that I think researchers and practitioners in the shared decision-making space have struggled with. I think what can sometimes get conflated is shared decision-making versus other types of techniques for communication, like motivational interviewing, that are structured to persuade. Shared decision-making is not or the tenets of shared decision making are not intended to be used in that way. So whether or not vaccinations are sort of an appropriate intervention to utilize shared decision making is a bit of an open question. But I think the key point here is that we have to think about shared decision making not as a way that not as a tool that we use to persuade our patients in the direction of a certain intervention or treatment or screening option that we hope that they take, but rather to really collaborate together on making a choice that makes sense for that patient, given the evidence, that they understand the evidence, and still after understanding the evidence, that they, in consideration of all the things that are going on in their life, choose a path that makes the most sense for them. So I would look towards other types of techniques of patient communication and risk communication, like motivational interviewing, when we're thinking more about persuading rather than collaborative decision making.
So along those lines, a follow-up question for that would be, so what is the distinction or differences between shared decision-making and informed decision-making?
Also a great question. Some would say that there is not a distinction between shared decision-making and informed decision-making. and that they're essentially the same terminology used to describe a very similar process. I think both definitions of shared decision making and informed decision making place the patient as the ultimate arbiter of choice, right? Ultimate arbiter of that decision and really the driver of decisions. I think where shared decision making, the definition of shared decision making perhaps differs somewhat, is that it focuses on what the provider can also do collaboratively with the patient to help them navigate those decisions. So, I myself as a patient certainly have walked into a physician's office and been given a lot of information about my options. I've perhaps felt informed right at the end of that conversation, but I didn't feel confident in being able to make that choice. And so shared decision making still calls on the provider to help the patient clarify their values, clarify their the aspects of their personal life that might mediate some of these choices, and actually participate with them in coming to a shared decision. So I think, I don't think that there's a lot of consensus about whether informed and shared decision making are the same thing or a different thing. But in my interpretation of shared decision making, I like to think of the provider as sort of continuing to take on a role of providing guidance and sort of helping that patient navigate the complexities of their choices.
Okay, and another question for, I guess, Jennifer and Marisha. Considering that for most guideline developers, there is the intent and willingness to have patients and public participation in different stages of the guideline development, but oftentimes lack of knowledge or about the guideline development process is a deterrent for some. Will education or guidance for patient and public participation in guideline development be addressed by Muse?
Yeah, so we will in the GIN Master checklist, the first topic has a section about training. And so we would recommend that appropriate training is provided, but we won't give guidance on what that training would be, just that the guideline development group should consider training. And what our patient and public co-leads have suggested is that that training should be developed by the patients and the public so that they're getting what they need in order to participate in the way that they want to participate. And Mara, is there anything else I should add or you want to add?
No, that's perfect. I went on mute about the same time as you, but that was a perfect response. I don't have anything else to add.
Okay. I don't see any other questions here. Are anyone on who have a question that they would like to post to the committee? We do have a few minutes left in our allotted time.
Can Jennifer post the link to the survey, please? Thank you.
I've just posted it in the chat. Thank you.
Okay, great. Thank you. Well, thanks, everyone. If there are no more questions for today, we are going to wrap at the top of the hour. Thank you so much for joining us for this webinar presentation from GIN North America. We thank you for taking the time to join us today, and please be on the lookout for other webinars coming up later on in the year. And remember, if you're not yet signed into GIN Connect, please do so and spread the word, as that is our main portal for communication and advertising these webinars. Thank you and have a great day. Thank you, everyone.